So, hello everyone. My name is Aslam Nehra, and for today, our topic is going to be spirometry. So, what is spirometry? Spirometry is a common type of pulmonary function test, which is also known as a lung function test. It measures the flow of air through your lungs and estimates the amount of air. It tells your healthcare provider that how strong your lungs are and how well you breathe. It is safe, and healthcare providers commonly order it to evaluate your lung function. Uh, Biomedical engineering plays a significant role. As you can see, these roles are mentioned here. Next slide. Now, before understanding spirometry, we need to understand the anatomy and physiology of respiration. So, respiration is the process of taking in oxygen and expelling carbon dioxide. This vital function is carried out by the respiratory system, which includes the lungs, airways, and muscles of respiration. You can understand the in-depth explanation through this diagrams. So, the upper respiratory tract is divided into two consists of nose, mouth, nasal cavity, pharynx, larynx, and the lower respiratory tract consists of trachea, which is also known as the windpipe, bronchi and bronchioles, and alveoli, where the gas exchange takes place with the blood. Now we have the principle of spirometry. So the fundamental principle of spirometry is the measurement of the volume and
Hello.
sorry guys, the Wi-Fi got disconnected. So yeah,
Yeah, you
carrying
can
on.
continue.
Uh, Measuring lung function, spirometry basically measures two key things. The first one is lung volume, which is how much air you can forcefully breathe out, also known as the forced vital capacity. Then we have the flow rate, which is how fast you can breathe that air out, especially in the first second. That is the flow rate. So these measurements help assess the health and capacity of the lungs. So the function of spirometry is airflow, which goes to the transducer and it converts into electrical signal, and then we get the graph. So now Gitanjali will explain the working principle.
So the working principle of spirometry, we have a couple of phases. The first one being the inhalation phase. Here the subject breathes deeply through a mouthpiece and it has a nose clip so that there is no leaks. The spirometer sensors, which can be like a pneumotachograph or the turbine, intercepts the airflow. Then we have the flow detection and conversion phase. Here, inside a transducer such as a pneumotachograph, measures pressure drop across a known resistance, translating it into airflow. Then we have the electrical signal processing phase. The transducer's analog output, like voltage variations, is then captured and digitized for analysis, producing precise readings of flow and volume over time. Spirogram generation is the last phase. Now, for simplicity purposes, I've kept a smartphone-enabled spirometers instrumentation diagram. Here we can see the different blocks of the whole spirometry. First one being the respiratory airflow inlet. Here the air from the patient enters the device through the airflow inlet. Then we have the differential pressure sensor. The sensor measures the pressure difference caused by the airflow, which affects the lung function. Then we have the preliminary signal conditioning. Here the signal is first conditioned to remove unwanted noise or irregularities. And then the analog to digital conversion. Here the analog signal is digitized using an ADC so that it can be processed by a microcontroller. The processing unit, here the processing unit calculates the respiratory parameters like volume and flow rate. The external storage is where the data can be stored for patient history, and then we have the Bluetooth transfer, where the results are sent via Bluetooth to a smartphone. Now we have the types of spirometers. Um, First, we have volume displacement spirometers. Volume displacement spirometers, a very popular example would be water seal type or the bell type. They volume directly and they are very accurate but bulky. Then we have flow sensing spirometers. Flow sensing spirometers measure airflow and integrate it to get volume. Under flow sensing spirometers, we have four types. First one being turbine spirometer, where the rotating vane detects the flow. Then we have the pneumotachograph, where the pressure difference is measured across the mesh. Then we have the ultrasonic spirometer, where the transit time of ultrasound waves changes with the airflow. And then we have the electronic or MEMS based spirometers, which are compact, portable, and digital. Now, going back to the instrumentation example with respect to the types of spirometers, we have sensors or transducers, which can be pneumotach, which measures the pressure drop across a resistive element, the turbine, which in where the flow rotates the vane, and the rotations help to figure out the volume, the ultrasonic, which measures the time delay of ultrasound waves in flowing air. Then we have the electronic components where we have the amplifiers for weak signals, analog to digital converter for digital recording, and the filters to remove noise. Under display and storage, we have real-time graph of the spirogram, data stored for the patient history and comparison. And accessories would be the mouthpiece, which is disposable for hygiene purposes, and an antibacterial filter. Over to Rida.
Now I would like to explain mathematical relation and graphs. First is FVC, force vital capacity. It's the total volume of air after a deep breath, the amount of volume of air in a person can exhale. Next is force expiratory volume in 1 second. It's the amount of the air the person can forcibly exhale in the first second of the maximal force expiration. Next is the diagnostic index, which is the FPV1 by FVC, is the calculated ratio in pulmonary function testing to diagnose obstructive and restrictive lung diseases. Next is peak expiratory flow, that is PEF. That's the maximal flow that can be exhaled when blowing out as fast as possible. Next is the spirogram graph. First is the normal lung disease pattern. As we can see, there is on the vertical axis is flow and on the horizontal axis is volume. The sharp and high peak for volume at start and then smooth decline as the lung is empty. So the FE1 is 105%, FVC, that is the forced vital capacity, is 103%, and the ratio is 89%. Next is the obstructive lung disease pattern. In this, there are, as we can see in the graph, there are narrow airways. Falls as we in the graph falls more as the graph falls more quickly during exhalation because the air is trapped and resistance is higher. Obstruction is when the airways is narrows because of the airway caliber through which the entire smooth muscle contraction is there or inflammation. Obstruction is characterized by the reduced force expiratory volume, that is 73%, or reduce in the FVC, that is 109%, and reduce in the ratio of diagnostic index, that is 53%. Next is destructive lung disease pattern. In this, the lungs are smaller or cannot expand, because of which there is loss in lung volume. As we can see in graph, the graph is narrow and taller. The height is present, but the lung volume is reduced. The reduced destructive is characterized by the reduced FVC, that is 82%, or reduced FVC is 85%. The ratio, diagnostic ratio is 84%, and the peak expiratory flow is 157%.
Is she audible?
Yeah. Now the biomedical applications. First is diagnosis of respiratory diseases for that detects COPD, asthma, pulmonary fibrosis early by measuring airflow limitations and lung volumes. That helps differentiate between obstructive and restrictive lung disease for targeted treatment. Next is preoperative assessment. It evaluates lung function before surgery to assess risk and plan anesthesia. Guide post-operative care for patients at risk for breathing complication. Next is occupational health monitoring. Tracks lung health of workers exposed to dust, chemicals, or fumes to prevent chronic diseases. It also enables early detection of workplace related respiratory problems to improve safety. Now is the case example of first is the normal lung function curve that is smooth, rapid in flow, and there is a gradual decline in the diagnostic index that is FE1 and FEC that is around 80%. The normal lung volumes and airflow. Next is an asthma patient, a scooped out appearance in the expiratory phase, reduced in forced expiratory volume, and the diagnostic index ratio, evidence of reversible airways obstruction. Now, recent advancement portable digital spirometers with Bluetooth. It is compact, easy to use devices for on go for testing. It has wireless data sensors to smartphones and computers. AI based interpretation, automated analysis for spirometry results. It helps in early detection and diagnosis of respiratory issues. Next is smartphone based spirometry apps. They are convenient, app based lung function monitoring. It enables self assessment and remote patient tracking. Next is the telemedicine integration, remote consultation with healthcare professionals. It also helps in seamless sharing of spirometry data for follow ups. Now, some advantages. They are simple, quick, and non invasive. They are cost effective, portable devices are there, objective assessment of airflow. They are useful for screening and diagnosis and follow up response for tooth therapy, aids for preoperative risk assessment, and fitness to work or play evaluations. Now, some limitations. First is the effort cooperation dependent or coach dependent too. They are not suitable for infants or very young or some older people, cognitively impaired patients. They are limited in ICU, the acute distress. It requires good seal and disease to prevent leak or poor effort distort result. It does not measure absolute lung volumes, that is RV and TLC, or diffusion capacity. Now, some safety and collaboration. Infection control, single use of disposable mouthpieces, inline bacterial viral filters, hand hygiene, clean disinfect equipments, and high touch surfaces between patients. Adequate room ventilation, consider PPE when cough expected, default testings for patients with suspected confirmed airborne disease. Follow local policy or ATS ARS or CDC styles guidance. Maintain a decontamination log. Calibration quality control. Daily 3-liter syringe calibration across low, medium, high flows, leaks test, zero flow check, enter ambient temperature, pressure or humidity. Weekly biologic control to detect drift. Very